Should we start?
Yes, sir.
You ready?
Yeah.
Right, great. Here we go. Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 18C, which is Hematology, Malignant, Lymphoid, and Plasmacytic diseases. We are streaming live from SGPGI Lucknow via Kolkata. And we have with us Dr. Ruchi Gupta, who's an MD from PGI Chandigarh. Presently, she is an additional professor, lab hematology at the Department of Hematology at the SGPGI Lucknow, with areas of interest in malignant hematology, MDS, AML, and multiple myelomas, benign hematology, thalassemias, and bleeding disorders, with multiple publications in national and international journals. Dr. Gupta will be speaking on the chronic lymphocytic leukemia, classification, morphology, flow, molecular prognostics, and risk classification. Before I ask her to start, let me request all of you to keep your mic muted, your camera off, and please do not share your screen. With this, let me request, ma'am, please share your screen. Let's start.
Is my screen visible, sir?
Yeah. Let's make it full screen.
Thank
Yeah,
you so
please start.
Yeah. Thank you so much, sir, for your kind introduction. It is indeed a pleasure to be back to this platform. And unlike the last talk which I had on AML, this is more of a, today's topic would be more like a seminar. And it was indeed very interesting to go through the pathogenesis of CLL again. And I really hope that the listeners also, find it equally interesting. And though everybody, I am sure, who's in the field of hematopathology has come across, cases of CLL, but nobody really, bothers to look at the pathogenesis. And there are so many more things to this entity than what, the peripheral smear with small mature lymphocytes and things like that tell us. So with that, I start the talk. And so, as I has already pointed out, this talk is basically going to cover all aspects of CLL. And the initial part might become a little boring for some of the people when I talk about the molecular pathogenesis, but subsequently Definitely, I hope it brings you back to interest when we talk about the diagnosis, that is stratification, and how do we actually nowadays plan to treat CLL, though it is a very indolent disorder. So, I think needless to say, CLL is the most prevalent type of leukemia in adults in the Western countries. And interestingly, in India, its incidence is almost 10 times lower than the Western world. This data was compiled by PGI Chandigarh from the clinical side, and it was very interesting to note that even though it is still the most prevalent, and usually everything in India is more as compared to the Western countries, but somehow the incidence of CLL is 10 times lower, and it's largely male preponderant, and this is one of those leukemias or lymphomas which has a high degree of first degree relative patients, and there is a 2 to 8 fold increased risk in those first degree relatives to develop CLL once somebody in their family has CLL. Though I'm not really sure how many patients with familial CLL we have actually seen, but this was interesting to read that it has a genetic familial background to it. And though the disease has a very stable course, but with time, as more and more additional genetic abnormalities develop, the disease can progress to a more aggressive form. And it's not the even the clinician is not trying to completely eradicate the disease. It is just that it becomes kind of quiescent with treatment, and then there can be relapses. And as and when more and more driver clones or subclones they evolve, it can transform into a more aggressive lymphoma. So this is just the background that we all know that CLL is typically characterized by CD5 positive B cells in the blood, bone marrow, or in the lymphoid tissues. It can have a leukemic presentation, which we commonly known as CLL, that is chronic lymphocytic leukemia, or if it is limited to the lymph nodes with no peripheral blood involvement and no cytopenias, we call it as small lymphocytic lymphoma. It can have extramedullary disease, and it also has a precursor lesion which is known as the monoclonal B cell lymphocytosis. The diagnosis largely relies on the morphological findings in the peripheral blood. That is, if you have a absolute lymphocyte count of more than 5,000 cells per microliter, and followed by typing those lymphoid cells and their typical immunophenotypic profile. How does genetic workup come in here? The genetic workup is actually has helped us to understand the course of the disease, and now there are markers which help us to decide whether we should sit back and wait and watch for this disease to evolve, let it progress, or are there markers by which we can decide that no, this is an aggressive disease and needs to be treated upfront. So, with this, I take you to the molecular pathogenesis of CLL. And one of the most intriguing aspect of CLL has always been the cell of origin. That what is that basic cell where which gives rise to this CLL clone. So, I must point out that even at the hematopoietic stem cell defect, it is known that there are the genetic abnormalities have been noted even at the hematopoietic stem cell level, because these stem cells, if xenografted into some immunodeficient mice, they can develop into oligoclonal and then full blown CLL like immunophenotypic cells. So this points out that there are certain abnormalities, or the people who go on to develop CLL have already some defect in the hematopoietic stem cells, and these are known as susceptibility loci, which are there in these patients as compared to the healthy donors. And these are usually these susceptibility loci are involving the transcription factors like TCF3, IKZF1, IRF8, and other transcription factors which are involved in cell proliferation and anti-apoptotic pathways. So coming to the cell of origin, so we used to believe for quite long time that these are probably naive B cells because there has been no antigenic stimulation and so on, or they are the CD5 positive B cells which are found in the peripheral blood of healthy adults, which are typically known as the B1 cells. But now this cell of origin is being mapped to the memory B cells, which has a CD27 positive and a CD5 positive phenotype. And because of the study of the immunoglobulin heavy chain variable mutation analysis, it has shown that a subset of these have actually interrogated an antigen and have undergone somatic hypermutation, while a subset of these CLL are actually naive, meaning thereby they do not pass through the germinal center. So based upon this, there are two broad subtypes of CLL cells depending upon the cell of origin. That is, they can be unmutated CLL, in which the immunoglobulin heavy chain variable mutation has not occurred, and it can be a mutated immunoglobulin heavy variable chain subset of CLL, where these cells have actually passed through the germinal center, have undergone somatic mutation, have been interacted by some antigen, and so a rearrangement in their immunoglobulin heavy chain has occurred. So this is one basic difference between between two individuals which will decide the course of the disease. The unmutated CLLs usually have a more aggressive behavior, whereas the mutated CLLs behave in a more indolent manner. So let us take the help of this beautiful diagram. It is from a Nature Reviews article, where they have shown the cell of origin and other abnormalities which are known to happen in CLL. As I already mentioned, that they say that this genetic and epigenetic lesions are supposedly there even in the hematopoietic stem cell, which lead to a CLL type of hematopoietic stem cell. And eventually, the cell which gives rise to these CLL is basically a mature B cell, but and is supposed to arise from this germinal center B cell, memory B cell, some which have undergone through the germinal center, that is the post germinal center cells, which will be CD5 positive, 27 positive, and this is usually a T cell dependent mechanism. Whereas the unmutated ones are those which are supposed to arise from these naive cells, which are pre germinal center, CD5 positive, and CD27 negative. And both these cells eventually will pass through the different phases of CLL life. It is believed that almost all cases of CLL, whether it is mutated CLL or unmutated CLL, all these have a precursor lesion of monoclonal B cell lymphocytosis. A constant antigenic stimulation results initially in a polyclonal proliferation. Subsequently, it becomes oligoclonal, and thereafter, this oligoclonal population results to a full-blown monoclonal population of cells. And depending on the cell count in the peripheral blood, they have been labeled as MBL, that is monoclonal B cell lymphocytosis, or frank CLL. In all this development from the naive to the typical mature clone of CLL, the B cell receptor signaling and the microenvironment are said to have a very, very important role. So before I move forward, this is something which even when we were students and even till date, even our senior residents, what is this IGHV exactly? So I'll just take a minute to explain what do we mean by this immunoglobulin heavy chain variable region mutation. So this is a typical immunoglobulin, and this is the blue gray is the constant region. This is for the heavy chain, and this is for the light chain. Whereas this variable heavy region of this immunoglobulin molecule, if you look, it comprises of this VDJ segments. You'll have to recapitulate your B cell ontogeny to recall that there used to be some rearrangements of the VDJ segments, which were actually responsible for deciding the antigen affinity in a B cell. The cells which successfully undergo this VDJ rearrangement are selected, whereas those which do not undergo this VDJ arrangement successfully meaning thereby that they have specific antigen specificity. अगर तो उस specific antigen के against develop होकर वो उस पे काम कर पा रहे हैं, तब तो ये cell will go on and proliferate. But if this rearrangement results in a non-specific kind of an antibody which is not able to combat the antigen, then that particular cell undergoes cell death. So if you look at this variable heavy region, it has these framework regions 1, 2, 3, and 4, and the CDRs, that is a complementarity determining regions 1, 2, and 3. So these complementarity determining regions are supposed to be most antibody contribute most to the antibody specificity. And when we talk about somatic hypermutation, this happens in the germinal center, where there is a random nucleotide change in this variable genes, selecting the B cells to promote immunoglobulin production with high selectivity against the particular target antigen. So if a cell has undergone somatic hypermutation, then the sequence of this region will differ from that of the germline genes. So if this difference in the sequence is more than 2%, then it is said to be a mutated immunoglobulin variable heavy chain, else it is considered as an unmutated. And how do you diagnose this? If you see, this is actually a very challenging job to perform this sequencing, because these are those regions which actually are so variable. Primers are designed against these different framework regions, and so that this entire area can be mapped. And once you have the sequence of the entire gene of that particular person, you map it with the germline sequence. If there is a deviation from the germline sequence, then that indicates that the cell has actually undergone somatic hypermutation, or indirectly indicating that the cell is a post-germinal center cell. So, and this since it involves a lot of sequencing, there are ways by which we can test this. We can do fragment analysis, we can do Sanger sequencing, but it is best diagnosed by next generation sequencing. So this IGHV is one of the major factors, whether it is mutated or unmutated, which decides the fate of an individual and subsequently how is the disease going to behave. So if we look at this, this is tabulating the difference between the unmutated CLL cell clone and versus the mutated. So the unmutated CLL cell clone actually has a tendency to accumulate more high risk genetic lesions and a higher propensity to undergo clonal evolution. Whereas in immunoglobulin heavy chain, which has a mutated variable region, they are usually associated with low risk genetic lesions and have a lower degree of tendency to clonal evolution. So, needless to say, this unmutated forms approximately 40% of all CLLs, whereas the mutated CL comprises of approximately 60% of the cases. And because of this difference, whether it is a mutated cell of origin or a cell which has unmutated, the course in an individual will differ, and it also eventually decides the activated signaling pathways which are involved in that particular cell, and it also decides the degree of interaction of these cells with the microenvironment. So what role does microenvironment play over here? So this is good prognosis and this is bad. So this is not really the last edited version which I am playing. I think इसके बाद मैंने कुछ changes किए थे, but I think probably I have downloaded the wrong file. Anyways, so if you talk about the microenvironment, there are a lot of cells in the microenvironment in the lymph node, particularly those in the proliferation centers. Everybody knows that there are large pale areas in lymph node of SLL, which are known as proliferation centers. So it is in these areas that these tumor cells interact with many non-tumoral bystander cells. These include the monocyte-derived nurse-like cells, the follicular dendritic cells, the endothelial cells, T cells, and in the bone marrow they interact with the bone marrow stromal cells. So this is a diagrammatic representation of all the different kind of interactions. And if you see these, a lot of chemokines and chemokine receptors are involved in ensuring that the CLL cell stays over there. It escapes apoptosis. It is not killed by the T cells. It stabilizes over there. So CD49D, which is now also used as a prognostic marker, it interacts with the cell adhesion molecule and this stabilizes the cell in that lymph node or in the bone marrow. Then it interacts with the follicular dendritic cell, which are responsible for preventing apoptosis of these cells. Then we have the B cell receptor, through which there is a constant autonomous signaling going on in this cell, because of which the cell is activated. Then we have the endothelial cells, the B cell maturation antigen, which are interacting with the monocyte nurse-like cells, and so on. So this is just to emphasize, like as we see in Hodgkin's lymphoma, that the RSL also has a good going microenvironment. Similarly, even the CLL has a large microenvironment which is responsible for multiple things. So this is again just a recap of what these B cells, T cells, stromal cells, and all these cells, they secrete many cytokines which are responsible for the survival, homing, migration, drug resistance for the specific CLL cells. So among the pathways which are actually involved in promoting the B cell survival and proliferation are through the B cell receptor. So B cell receptor normally should undergo activation when it interacts with an antigen. But what happens in CLL is that there is an autonomous signaling capacity, because of which the PCR gets activated independent of the presence or absence of an antigen, and this signaling is crucial for the crucial pathogenetic mechanism for the evolution of CLL. So people who are listening to the class, might say कि ma'am क्या पढ़ाया जा रही है यार, ये इतना theoretical, why is she talking about all this? So I'll just take a minute to emphasize why this is all important, because these are now, this is what is being targeted. If you look at the novel agents which are coming up, so they are targeting these downstream pathways like glutathione tyrosine kinase inhibitors, ibrutinib. This is being a standard now used as a standard of care therapy for treating CLL patients. The drugs like FCR, fludarabine, bendamustine, and chlorambucil, this is the typical drug combination which is given to adult patients who are less than 65 years of age. Unfortunately, this has a lot of cytotoxicity, so we end up giving R-benda or bendamustine with chlorambucil and so on. But the point is that you really need to understand the pathogenesis better so that these proteins or these targets can be used for the development of newer drugs, especially in patients who are evolving to a more refractory or a relapse kind of a disease, where your conventional therapy is failing to give you an optimal therapy response. So, what we have studied so far, what is the cell of origin, what is the role of microenvironment. Now, coming on to the CLL cell per se. So, what are the genetic abnormalities in that B cell in itself? How many mutations and what types of mutations are there in that particular CLL cell? So, a typical genome of CLL carries more than 2000 molecular lesions, and up to 80% of patients at diagnosis carry cytogenetically detectable recurrent chromosomal abnormalities ranging from 1 to 4. And with the identification of these genetic abnormalities, the first molecular classification, also known as the donor classification, was proposed based on the use of fish, which was useful for predicting disease progression and survival. And naturally, deletion 17p was the one which has had the poorest outcome, followed by deletion 11q, trisomy 12, normal fish, and followed by isolated deletion 13q. So again, this is a bar diagram showing the huge number of genes which are altered in CLL, and they have been grouped under like those which are involved in cell cycle, those involved in notch signaling, in RNA processing, DNA damage, and so on, and B cell receptor activation and through toll-like receptors or via NF-kappa B. And again, the purple bars highlight the abnormalities in the cells which have an unmutated phenotype, whereas the orange or whatever color you call this is those which is representing the cells in which there is which have undergone this immunoglobulin heavy variable region mutation. So it is clearly evident that these purple bars are taller over here. So the cells which have an unmutated genotype, there the frequency of these bad mutations like notch, deletion 11, deletion 17, ATM gene mutations, and again over here the BIRC3, again these are those which are anti-apoptotic and pro-survival or pro-proliferation. So there is a higher accumulation of these genetic abnormalities in cases which have a unmutated genotype as compared to the mutated. And moreover, if you see, since deletion 13q has been noted to be one of the primary or initial abnormalities, like the first clones which are formed in CLL, majority of the patients will have this abnormality. Whereas abnormalities like deletion 11q or 17p deletion are initially present at a very low percentage, and they are said to evolve with time, or if they are present initially, they'll be very small clones or sub clones, and gradually with time, when you give treatment or you wait and watch whether treatment is to be given or not, these clones can become the major clone, and the other clones will become the minority. So again, just with the help of another diagram, just to emphasize that the accumulation of different driver mutations, like I said, the B cell receptor pathways, the MAP kinase pathway, initially the abnormalities of the cell cycle genes or the DNA damage response genes are to the tune of 5 to 10%, but they increase to the tune of 20 to 30% in patients who have a progressive disease. The same applies true for Notch1 mutations, NF-kappa B, TP53, ATM genes, and so on. So some of these mutations like SF3B1, POT1, ATM are more frequent in patients who require therapy, and some are those which are seen to be more frequent in patients who have progressive disease even after they have received therapy. So the importance of these testing these gene cells that help to decide what therapy is to be given and whom therapy should be given. So this is just a diagrammatic representation of what I just said: disease progression, the rise and fall of the minority clones, and so on. So if you see initially, this is the small clone of CLL cell, which, since the clone was small initially at diagnosis, so the best treatment offered to the patient was wait and watch. Gradually, during that period, another clone has evolved. Now you have started treatment since the patient must be manifesting symptoms accordingly. This is the first relapse when you can see that the initial clone as well as the newer clone has come up. And in relapse 2, there is a combination of the original clone plus the relapsed clone. There are other situations where the original clone has completely disappeared, and now in the second relapse after treatment, all you have is a newer clone of cells plus another D3 clone, which will probably lead to an even poorer outcome. And such patients are very difficult to treat with current therapeutic targets, and that is why we need to understand the disease pathogenesis so that newer drugs can be developed for identification of markers which can be used for the treatment of such patients where these new clones keep on cropping up. So if somebody says इतनी देर से पढ़ा रहे हो पता नहीं nutshell क्या पढ़ाया. So then this is a word cloud. One of my residents taught me. This is depicting the different genes which are involved in the pathogenesis of CLL, and the font size is reflecting the is frequency of abnormality. So like deletion 13q is the most common abnormality, and followed by probably trisomy 12, SF3B1, Notch1. Then 5 to 10% of TP50 patients have TP53 and ATM. And probably if we draw this word cloud on the basis of prognostic markers, then I think TP53 would probably find the largest font, followed by ATM, and now gradually Notch1 and SF3B1 are also found to have if they are present in a particular patient, then they are inferring a poor prognosis to him. So this cytogenetic abnormalities, which I just discussed before, that deletion 17p, deletion 13q, trisomy 12, and so on, when they are clubbed together with the molecular abnormalities, you can develop a risk stratification. If we see over here, presence of deletion 13q alone or a normal fish study has an overall survival of almost 68.1% or 72%. But a good going number, that is 20% of these patients, may simultaneously be harboring either Notch1 mutations, SF3B1, or TP53, which almost results in halving their 10-year overall survival. So these are those key abnormalities which find a place in deciding in the current era what patients should be taken up for treatment directly and which patients can be taken up just as a follow up to see how the disease behaves. And if we see, these are the different pathways which are involved in CLL evolution and progression. So if you look at MBL, that is the monoclonal B cell lymphocytosis, the abnormalities have been clubbed in one single column. Whereas if you move on to CLL, it has become double column and so on. So just joking. The point is that from MBL to CLL, if you see the degree of abnormalities, they are increasing. And further on, the role of Notch1, TP53, SF3B1 and BIRC3 becomes more important when the disease is either in a phase of drug resistance or has progressed onto a DLBCL type morphology, that is the Richter syndrome. So if we see here, the incidence of Notch1 mutations is as high as 40% as compared to hardly 10% in the initial stage of CLL. So TP53 overall has become one of the best documented predictors of poor survival and refractoriness in CLL. So just a few words about the monoclonal B cell lymphocytosis. It is believed that almost all CLL patients, have this precursor MBL, which may or may not be picked up. And people who have gone on to do flow cytometry in healthy individuals, it was observed that 5 to 12% incidence was noted in the general population in more than 40 years of age. Whereas in first degree relatives of CLL, it was found to be to the tune of 13 to 18%. So MBL can further be divided into low count and high count. The low count MBL, the cutoff is 500 cells per microliter. The low count MBL has almost a negligible risk to progress to CLL and it is more like a stable MBL. Whereas the high count MBL has a much more higher tendency to, though it accounts only for 2% of the MBLs, but it has a much higher risk of progression to CLL. So if we look at so high count MBL, the risk is approximately 1 to 2% per year. So if you look at the immunophenotype of these cells, the majority of them have a CLL-like immunophenotype, typically 523 positive, 19 positive, and so on. But a small percentage can have an atypical phenotype where CD20 is brighter and surface immunoglobulins are bright. There can also be a CD5 negative MBL, though I must agree that it would be probably difficult to categorize these cells. And by definition, these the percentage of these cells, or the absolute number, is usually less than 5,000 cells per microliter. The genetics in MBL is similar to CLL, as I just showed in that diagram over here. So even MBL cell is harboring the similar mutations which are there in CLL, but the percentage of cases which are showing notch mutation or deletion 11q is even smaller than that which is seen in CLL. So if somebody asks me a summary of CLL, how does a CLL evolve? So this is basically a diagrammatic representation of the same. A constant antigenic stimulation has is believed is there, which results in a oligoclonal B cell proliferation. From this oligoclonal proliferation, there is subsequently a low count MBL. It can progress down to a high count MBL, or it can continue as a stable monoclonal B cell disease, further into a full blown case of CLL, which can either, when it progresses due to the development or acquisition of more driver mutations, can transform into a refractory CLL when the patient is treated, or these patients may go on to develop Richter syndrome. So, just a few words about Richter transformation as well. So, this is actually an aggressive transformation of CLL with a cumulative incidence of 5 to 10%. It has the same immunoglobulin rearrangements as those preceding in CLL, but as just discussed, that mutations in Notch1, SF3B1, and TP53 are much higher when we study these cases. So, this morphologically resembles DLBCL, but at the genetic level, if you see, the MYC rearrangements are found over here, but other profile of DLBCL like the ABC and the GCB type are not seen in Richter transformation. So what is more frequently seen are the TP53 mutations, the Notch1, the cyclin dependent kinases, and this genetic profile is totally different from that of DLBCL. This Richter transformation has a very poor prognosis. Very rarely, but CLL can also go on to progress to a Hodgkin's lymphoma. So, with that, I am done with the part. People who have slept off can please get up, and we can move on to a little more interesting part of the disease, that is the diagnostic aspects. So, diagnosis largely starts with the peripheral blood smear, and once you see those lymphocytes, the next thing you need to do is to type them. Then, before you actually decide what is to be done with these abnormalities, you need to do a FISH to detect what is the risk of the disease, what is the expected behavior of the disease. You can do immunoglobulin heavy variable chain mutation analysis by fragment analysis or sequencing, as I just mentioned before also. So clinically, if you see majority of the patients, if they are referred, some of them might just be asymptomatic, and some degree of lymphocytosis has been observed. Some may present with fatigue or features of autoimmune hemolytic anemia, infections, splenomegaly, lymphadenopathy, and so on. A small M component might also be seen in a very small percentage of patients. But this M component has nothing to do with the behavior, though it is said that if it may contribute, to an inferior survival, but that has not really been proven in the larger studies. So typically, what we see in a case of CLL is more than 5,000 clonal B cells in the peripheral blood, which are persisting for more than 3 months. The smear examination will show a small mature lymphoid cells. If you ask them independently from how to discriminate them from a mature lymphocyte otherwise in the peripheral smear, then I would say there is no way of doing that. Though some of the mature lymphocytes of CLL have a that golf ball like nuclear contours, and there are a lot of smudge cells which are there. There will be a variable admixture with larger cells, some which might be having a prominent nucleolus, some which might be having a cleaved nuclei, but largely then the cells are usually small mature in a typical case of CLL. The clonality has to be documented by flow, and if it is a case of small lymphocytic lymphoma, then usually you will receive a case of a lymph node biopsy, and usually there is no cytopenias, and subsequent to reporting the histopath, you need to do a bone marrow examination to rule out that there is no infiltrate. So this is a typical picture of CLL. The counts are usually high, hemoglobin usually preserved, there is no thrombocytopenias in the early stage of the disease. Anemia and thrombocytopenia usually indicate that the disease has progressed. So if this is how we see a peripheral smear, the first thing we need to do is to document that it is a cell of B cell origin. So that for that we usually use CD19 and CD20. I'm not going to go through the entire flowchart. What I really want to emphasize is that CLL is one case where the intensity of CD20 is less than CD19, and this is very important clue which tells us in even in the initial analysis that okay, so we are dealing with a cell which is brighter, which has brighter 19, and 20 is dimmer. So that is typical of CLL, though it might also be seen in some cases of LPL, right? So once you have shown that it is a B cell, cell or of origin which is proliferating, next what we can do is we narrow down it to 5 positive, 10 negative, and that standard approach which we have for BCLPDs. So CLL will naturally fall in that category of CD5 positive and 10 negative. And with similar morphology, we can also have differentials like follicular lymphoma, marginal zone lymphomas. LPL may, I would say that usually you have a more plasmacytic differentiation, and rouleau formation is also quite frequently appreciated. So though if you look at the cell individually, it might come as a DD for CLL, but usually LPL has a different kind of a manifestation. A closed DD would be mantle cell. Then the cells where we know, let us, so I'll be moving to PLL in subsequent slides. So after 5 and 10 has narrowed down to this subgroup of 5 positive and 10 negatives, then you need to study whether what is the expression of CD200, because now there are papers which have reported that CD200 has almost 100% specificity for CLL. So this is we published this I think in 2017 or 16, and we studied 160 samples for the expression of CD200 and the utility of CD200 in differential diagnosis of mature B cell neoplasm. So almost yeah, all 100% cases of CLL showed. Even hairy cell leukemia 100% cases showed CD200, but CD200 was brightest. The mean fluorescence intensity of 200 was brightest for hairy cell leukemia, and obviously hairy cell leukemia has its own otherwise typical immunophenotype, so it is not a trouble to differentiate CLL from hairy cell leukemia. One of the most important utility of CD200 is to discriminate CLL from CD5 positive mantle cell lymphoma, which is usually CD200 negative, though rare cases of CD200 positive mantle cell lymphoma have also been reported. There was another such paper from TMH where the diagnostic utility of CD200 and CD43 was studied for differentiating CLL from other mature B cell NHLs. And again, they also observed that CD200 and CD43 together had almost 100% specificity for CLL, including CLL, PL, and PLL, that is the pro-lymphocytic leukemia, right? So this is one of the recent articles where a European research initiative on CLL and the European Society for Clinical Cell Analysis, they proposed a harmonization of what all markers should be used in CLL. So what they have drafted is that what are the antigens which are required, and further what all are recommended. So I think it is needless to say that 19, 5, 23, 20 and a weak expression of the surface immunoglobulins is one of the in one single tube you can discriminate that this is possibly a case of CLL. Additionally, what we can use is CD43, CD79B, CD81, CD200, and CD10 ROR1. So these are other markers which are recommended, but they are being put up on a individual lab basis. Similarly, they said that even CD38, if you see, it is not really included even in the recommended panel, but CD38, ZAP70, and CD49D, these are prognostic markers which a lab will have to take its own decision whether they need to be primarily there in the panel or not. So with that, I'll show you just one or two examples of flow cytometry from our own center. So we have gated, if we see the first plot of forward scatter and side scatter, the cells are predominantly small and they are bright positive for CD45. Thanks to Dr. Rahman, we have drafted this lymphoid screening tube where in the first go, he has combined CD19 with CD4. So this is the population which is 19 positive, and again, this is plotted against CD3. So these are all our CD3 positive T lymphocytes. So what we can appreciate that there is a major chunk of cells which are positive for CD19. They are also positive for 20, and while they are negative for CD10. The blue cells are the T cells, and obviously these are the ones which are positive for 8. Whereas this green population, which is CD19 positive population, is negative for CD10. There is a dim expression of 5, but 200 is positive. 20, as expected, it is a heterogeneous expression. You see, this is ranging from almost 10 is to power 2 to 10 is to power 4. Whereas if you see the expression of CD19, it is crossing even crossing 10 log 4 log on the MFI. So this is one feature which helps us to identify that probably this is a case of CLL. Further, there is clonality for kappa light chain. FMC7 is negative, so this particular case is expressing CD49D, and it is also positive for CD23. So this is a typical phenotype of CLL. And another case, again, more or less the same findings, that positive for CD45, 19 bright positive, 200 is brightly positive, whereas 20 is heterogeneously expressed, again from 10 to power 2 to 10 to power 4. CD5 is positive. You really need to take your T lymphocytes into consideration when you are interpreting the expression of CD5. CD22 is positive, 38 negative, and CD23 is positive. So more or less, if you see CD19, 523, 43, 200, and we are not using ROR1 at our center, but I really don't think we are missing out any cases. And a dim surface expression of the light chain. Very frequently, I personally feel that we have a difficult time comparing whether it is a kappa restricted population or a lambda restricted population. So even the light chain expression is pretty dim sometimes on these CLL cells, besides the dim expression of 79B and CD22. This is how a typical lymph node would look like. A phased architecture, small cells, no mitosis. The pseudofollicles or the proliferation centers are paler areas with larger cells, and they are supposed to be the areas where there is maximum interaction with the tumor microenvironment. And a typical immunophenotype on documented on immunohistochemistry: 20 positive, 5 positive, again 23 positive, and I've just purposefully included an image of IHC of CD3 to show that CD5 is much more positive as compared to CD3. So the expression of CD5 is actually correlating with that of CD20 and not with that of the T cells. So this is how you evaluate the pattern of CD5 expression in a case of SLL. So a few words about PLL. So whether it is two coins or two sides of the same coin, I found this title very catchy. So PLL, if you see now, this is how a PLL would probably look like. There are some smudge cells, some mature lymphoid cells, but then cells with a very prominent punched out nucleolus. I'm really sorry for the photo being out of focus, or it is fine. So these we suspect PLL when such kind of cells comprise more than 55% of the peripheral blood lymphoid cells. There is it has been shown that this correlates with a poor prognosis, poor treatment response, and is frequently associated with splenomegaly. We expect that such cases would not really have a typical CLL-like phenotype as well. And at the genetic level, we are expecting to get trisomy 12. For this kind of a morphology, if you ask me differential diagnosis, I would say a hairy cell variant, maybe a mantle cell lymphoma with a blastic morphology, and I don't know MZL क्यों लिखा मैंने, but I think hairy cell leukemia variant and mantle cell lymphoma. I okay. So marginal zone lymphoma, because this is likely to come out to be a 5-10 negative, where you start suspecting marginal zone lymphomas, plus you have a splenomegaly. So that MZL comes as a DD because of these two or three different conditions. Otherwise, ये punched out nucleolus जो होता है ना, this is very typical of a case of prolymphocyte. So PLL, if you see, if comprises of less than 1% of all BNHs, it is more aggressive, more frequently found in elderly individuals. Usually there is more marked splenomegaly and minimal lymphadenopathy, rapidly rising lymphocyte count. There is no defined specific immunophenotype for PLL. It can be 5 positive, it can be 5 negative. It usually shows strong expression of the surface immunoglobulins, contrary to what is seen in CLL. And again, it will show good going expression of CD22, 20. Here, CD20 expression would be almost equal or even brighter than CD19. and even FMC7 can be positive. So, when the genotyping of BPLL was done, it is now believed that it is more closer to mantle cell lymphoma than CLL. And there was even a paper where it is shown that this BPLL is probably a spectrum ranging from CLL like PLL to a leukemic mantle cell like BPLL or a nodal mantle cell like BPLL, because even 1114 translocation has been found to be seen in approximately 20% of the cases. And unlike the B cell receptor pathway and other genetic abnormalities which are more rampant in CLL, the c-Myc pathway seems to be a more crucial molecule for the BPLL pathogenesis. Thereby, this BPLL is now not really taken as a, I would say, part of CLL, बट एज अ मॉर्फोलॉजिस्ट हम लोग हमेशा ये वाले सेल्स देखते ही हैं, सो ये डी आता ही है, ये हम डिस्कस करते ही हैं, एंड वन शुड बी अवेयर ऑफ द typical morphology of PLL so that you can discriminate that from CLL. So this is one of the cases iska when we did a immunophenotyping. So again, what we can see that these are largely B cells, these are our T cells, and these B cells are negative for 5 as well as 200. 20 is brighter as was expected. There is a brighter clonality and kappa is positive, 49D is positive, and CD23 is positive. So 5, though it is 5 negative, but again we have CD23, 20 brighter. So BPL doesn't really have any specific immunophenotype, and you'll have to take into account the clinical pictures, the morphology before you, and sometimes you'll eventually have to sign out as a differential diagnosis that it is probably BPLL, or I'm not sure, even a hairy cell leukemia variant. If you can show it is 103 positive maybe and negative again for 25 and 123 and so on. So even that, these markers will also come into play before you actually say that this is BPLL. This is a very old case which I keep in all my presentations. So needless to say, you can see that these cells are very large. They are almost 2 to 3 times the size of a RBC. This was in a 60-70-year-old female who was actually a known case of CLL, and who had presented to us with increasing lymphoid size of the lymph nodes, and she had started developing some degree of cytopenias. So the peripheral smear revealed that there was now a blastic morphology. So I'm sure you can appreciate that this is different from the PLL like punched out nucleus. This is a cell actually which has a blastic appearance, high NC ratio, and 1 to 2 nucleoli. Again over here similar findings. So when we did a flow cytometry for this case, this dates back to 2012, though we have seen more cases thereafter, but this is the one which is there in my records, so I bring this up again and again. So again, this is CD5 positive, 19 positive, CD20 is positive, but if you see 22 is dim, there is dim 23, FMC7 is negative, 25, 103, etc. All 34 were negative. So given that this was actually a patient of CLL, now which had progressed to increasing size of the lymph nodes and cytopenia, so a possibility of Richter transformation in a known case of CLL was suggested. And if you see, when you look up literature, you will realize that even when there is a Richter transformation, there is minimal modulation of the antigenic expression of these cells. Though morphologically they become blast-like, but they might express 5, they might not express 5, but the point is that they kind of retain the immunophenotype closely. In quite a significant number of cases, their immunophenotype would be like that of the CLL. And plus, if you really go ahead and do a genetic testing, as I said, it will not be typical of what you get in DLBCLs. Rather, it will be more of a Richter syndrome of CLL. So with that, I think there is no confusion as to how should you go about and establish a diagnosis of CLL. Once you have done the diagnostic part, then the next thing you need to do is, as I already mentioned, you need to do FISH studies to document and stage the disease, whether there is presence or absence of TP53 mutation, deletion 11, that is the ATM gene, or trisomy 12, because these are at least those which are clinically relevant at the time being. So now that I have diagnosed the patient and we have done all this testing, so how do we go ahead and risk stratify these patients? We can use the clinical staging systems, and then we have the molecular stratification, and combining the two, we'll have some prognostic indices. So the clinical stages, this is a very age old Rye and Binet classification, which is based on the presence of the degree of lymphocytosis with no cytopenias, is classified as zero. And I've taken this table just to show you what is the degree of median survival for patients who are in the low risk of Rye stage. Again, 1 and 2 have been clubbed as intermediate risk now, where you have lymphadenopathy plus minus splenomegaly plus minus hepatomegaly. So the median survival is still 7 years. And high risk are those who subsequently go on to develop cytopenias, where the median survival has dropped significantly. In the Binet, has been divided. In the Binet group divides the stage of the disease into stage A, B, and C. Stage A is when there are fewer than 3 areas of lymphadenopathy, no anemia, thrombocytopenia. Again, in stage B, where there are more than 3 areas of involvement, but again, no cytopenias. And stage C, where cytopenias develop. So basically, indirectly, what uh, we are able to assimilate is that patients who have cytopenias are actually high risk disease, and these are definitely that group of patients who cannot be kept for wait and watch, and it has to be intervened and they have to be taken up for treatment. So if we combine the molecular and the fish abnormalities, again we can develop a risk stratification system of high risk, intermediate, low, and very low risk. The high risk people are those who have a TP53 mutation or a mutation involving the BIRC3. This gene is also involved in regulation of the cell cycle and I think cell death. So its working mimics close to TP53. These cases account for 15 to 20% cases of the newly diagnosed CLL, and if you look, the 10-year survival of these patients is hardly 30%. Subsequently, in intermediate risk, you have those which are Notch1 mutated or SF3B1 mutated, or there is deletion of 11q, and obviously TP53 or the BIRC3 mutation is absent. The low risk trisomy 12 comes under low risk along with normal genetics, whereas deletion 13q alone with no other addition abnormality qualifies for a very low risk. So these are that subgroup of patients who really you need not bother about starting treatment. So this is one of the fish images from our center, thanks to Dr. Manish, who set up the cytogenetics lab in our department. So what he's given me is that these are the probes which are labeling the centromere of chromosome 17 and the short arm. So what we can see that one of the red signals is missing, so that is indicating that there is a 17p deletion, but there is not monosomy 17. That is what he's told me. And again, this is here you can see that the second red signal is missing. So the second red signal has mapped or has been used to label the 17p area, which has been shown over here, 11.1 to q11.1, and so there is a deletion of 17p over here. And this is another case where we have trisomy 12. Normally any gene has two alleles, but so you expect only two signals, but here you have three signals of chromosome 12, so thereby indicating that there is a trisomy of chromosome 12. So in our department currently we are doing deletion 11q, TP53 mutation, and evaluating patients for trisomy 12. So now that you know the clinical staging, you know the molecular staging and the fish-based prognostic scoring. So these are the two prognostic indices. This is one of the German CLL scoring group, prognostic index, and this is the CLL IPI. So the biomarkers here you have in the German group, there are approximately 7 biomarkers which have been given a score of 0 to 1, as opposed to the IPI where age, stage, beta microglobulin, immunoglobulin variable chain, mutated or unmutated, what is the status, and what is the status of TP53. So no abnormality, more abnormality present or not. So accordingly, they have divided the patients into low risk, intermediate risk, high risk, and very high risk. And if I'm not mistaken, definitely the low risk patients are those which are who do not require treatment. Intermediate risk would be those who you need to closely wait and watch, and if any of these abnormalities are present, then you probably need to take them up for. सो सी ए TP53 म्यूटेशन को स्कोर 4 दे रखा है, तो यानी वो ऑटोमेटिकली हाई रिस्क में चला गया. आई थिंक ओवर हियर ऑल्सो इफ वी सी 17p13 deleted is given a score of 6, so automatically it shifts onto a high risk. So this is one of the, I would say, deciding factors currently, which is mandatory to take a call whether how to take this patient for treatment. So I'll be briefly touching upon this part. So as I already mentioned that the CLL IPI divides the patients into low, intermediate, high risk and very high risk. So the low risk as well as the intermediate risk, they are saying do not treat unless until the disease is symptomatic. And high risk and very high risk, definitely you need to treat except if the disease is asymptomatic. And before you start treatment, this is a short or a small algorithm. The first and the foremost thing which they have seen is whether the TP53 mutation is present or absent. If it is mutated, then you directly need to go ahead for kinase inhibitors or drugs like ibrutinib. And if it is wild type, then the next thing you need to check whether you have this mutated IGHV or the unmutated. Since unmutated has a bad prognosis, then that is why it is recommended to take up these patients also on kinase inhibitors. But if it is mutated, then you might suffice to start these patients with chemoimmunotherapy. That is, in chemotherapy, you have fludarabine, bendamustine, chlorambucil, and anti-CD20, that is rituximab, and newer agents can be given. So this FCR is the fludarabine, chlorambucil, and rituximab are the drug of choice for individuals who are less than 65 years of age. And I'll not talk much more about therapy. I think you need to talk to a clinical consultant for that. But what I was discussing with my colleagues, so CLL may usually FCR Indian scenario mein it has a lot of toxicity, so they end up giving two drugs. So bendamustine and rituximab are good going, and after they have given 6 cycles, they assess and they are not really bothered to eradicate the disease. It is just that you need to make it very quiescent, and patient को maintenance पे भी नहीं रखते हैं फिर उसके बाद, and they just follow up the patient to see when does the disease relapse or progress, and then accordingly they plan for a treatment accordingly. So this, I would just like to add, this mutation status of the immunoglobulin heavy chain is a very stable thing. If it is there at the time of diagnosis, it stays the same over period of time. It does not change. Though definitely TP53 mutation might not be present as a major clone initially, and when the disease evolves, these clones which are TP53 mutation may increase. So I don't think I'll go through this completely, but there are specific indications. That is when do you call a patient symptomatic, and when it is indicated that you need to start the therapy. So progressive myelofailures, that is being indicated indirectly by the anemias and the thrombocytopenia, massive spleen, massive lymph nodes, progressive lymphocytosis with a doubling time of more than 50% over a period of 2 months. No, with more than 50% increase over 2 months, or a lymphocyte doubling time of less than 6 months. Then if the patient has autoimmune complications which is not responding to corticosteroid, and if the patient has B symptoms, that is fever, weight loss significant, which are because of the disease per se. So I'm almost coming to the end of the talk. हम पहुंच गए हैं, हमने CLL का पढ़ भी लिया, पैथोजेनेसिस भी देख लिया, हमने फ्लो भी कर लिया, डायग्नोज भी कर लिया, ट्रीटमेंट भी दे दिया. अब क्या करना है? So like in our other leukemias, the role of MRD is not much talked about in CLL, at least मेरी जानकारी के हिसाब से, but it is there, it is coming up. What are the recommendations that you can do it either by peripheral blood or bone marrow, or if your peripheral blood is negative, then definitely you need to go ahead and check from the bone marrow. But if your peripheral blood sample is positive, then that would suffice to call it as MRD positive. What is the timing for at which this MRD analysis should be done? Usually for fixed duration therapies, MRD testing is done at least 2 months after completion of the last cycle, or if you feel that after the best treatment response has been obtained. And the degree of MRD assessment is same as we talk about in BLL and TLL, 1 cell and 10 to power -4 or -5. That is what we are targeting, and is also known as undetected or unmeasurable MRD even in CLL. And people or the patients who actually achieve this undetectable MRD are definitely supposed to have a much more better survival as compared to that which is the assessment which is being done by conventional standard responses based upon just the peripheral blood counts or the bone marrow lymphocyte percentage reduction. So how do you do MRD? The same. You can use 4-color flow, you can use 6-color flow, 8-color flow. The advantage of flow is that it is a very easy in centers which are doing routine hematology flow. But the disadvantage is that you require fresh samples. But you do not really need a old immunophenotype because CLL का phenotype would be more or less a kind of a stable cell phenotype, और आपको वो detect करना ही है by using those markers which were present in the at the time of diagnosis. But if you go ahead with the immunoglobulin heavy chain rearrangement studies, then you need to design patient specific primers. So you need to know the sequence of that gene which was present at the time of diagnosis, so that you can directly amplify that and check for the presence of the residual clones. This is just the Kaplan-Meier curves, which are showing that in a patient who is MRD negative and achieved CR versus a patient who is MRD positive and yet has achieved CR by typical definitions of count less than 4,000 and less than 30% in the bone marrow lymphocytes less than 30%. So there is a clear-cut difference in the clinical outcome, in the progression-free survival as well as overall survival for patients. Definitely, I needless to say that the people who become MRD negative and achieve remission would always fare better than people who are MRD positive and have otherwise achieved CR. Though what I feel is that progression-free survival has a much more marked difference as compared to the overall survival. So coming to the end, एक घंटे से मैं बोल रही हूँ. I really hope you have now a better, understanding of CLL. And there are some very beautiful articles on CLL which I would recommend that you should, definitely go ahead and study. So CLL, as we discussed, is otherwise an indolent disease, though it will never, kind of die off on its own or something of like that. But it has a long going course, and there are factors which can help to decide whether the disease is going to behave in an indolent manner or it is going to have a aggressive behavior. And this depends upon the cell of origin, the genetic lesions which are there like Notch1, TP53, SF3B1, etc., and the microenvironmental interactions. The diagnosis is really more or less straightforward in typical cases of CLL. Peripheral blood से या morphology देख करके, any hematopathologist is able to usually say with diagnostic accuracy of, I would say, 80 to 90% कि ये लो CLL है. But there are atypical cases and sometimes पता चलता है कि वो TPLL, some lymphoma of a T cell lineage comes out और वो googly हो जाती है. But otherwise, the morphology, the smudge cells, the preserved counts and so on. So they are diagnostic for CLL. At the molecular level, as I already said, that before you do anything for risk stratification, we really need to study these markers. Then treatment mein, the use of Bruton tyrosine kinase inhibitors and ibrutinib has kind of slightly overcome the difference in the outcome of IGHV mutated versus unmutated CLL. But in India also ibrutinib has come in. So this is available, and other novel agents need to be explored as and when newer information about the genetic lesions comes up. That is all. Thank you. So this was definitely not the presentation which was supposed to be my final presentation, क्योंकि उसमें मैंने thank you भी लिख दिया था.
Thank you so much, Dr. Ruchi. Excellently done. The fluency of the talk is an expression of the confidence in the subject.
Thank you, sir.
Great. Let's wait and see if there are any questions. Dinesh is there, Dr. Kusum Gupta is there, and there are quite a few others on the YouTube. Just let's hold on.
Sure, sir.
All right. I don't think so that there are any questions as of now. And if there are any, I will put it to you on your email.
Sure, sir.
Must be tired.
हाँ, मैं भी देख रही हूँ सर. मैं पूरा 1 घंटा मैंने बोल लिया. मुझे लगा था कि मैं तो तेज बोलती हूँ, मुझे 40-45 मिनट्स में हो जाएगा मेरा. So there's one thing, many people ask, do we really need to do a bone marrow biopsy in CLL or a bone marrow in CLL? So I have not really dealt that topic, but I think it's not required. There's really no additional information which we gain out of doing bone marrow and CLL, for at least for the diagnostic purpose. And if I'm not mistaken, I'll confirm with Manish as well that he can carry out FISH and all other studies even on the peripheral blood samples. So even a peripheral blood sample is sufficient, to diagnose and go ahead and treat CLL. A marrow is usually not required at the time of diagnosis, at least.
Okay. So just let me see if there are any more questions. What about lymph node biopsy?
Uh, Lymph node biopsies are agar if there is really nothing in the peripheral blood, then definitely when we are suspecting a low grade lymphoma and he has come with a lymph node alone, tab to sir we'll have to go ahead and do a biopsy and diagnose. But it really brings me back to the point we recently had a case and I didn't purposefully show that case because उसमें हम उल्टा गए थे. We first received the lymph node and we were really not able to pinpoint because there were some cells which are expressing 5, then there were some cells which are also expressing CD10, and we got hold of the patient later on, and then when we realized कि जब उसका peripheral blood किया तो उसमें relative lymphocytosis था and marrow में then it had a CLL immunophenotype. So ये so one thing I still remember Dr. Radhika used to tell us, and हम लोग एकदम उसको नियम से सर करते थे कि whenever you used to do an FNA of the lymph node, we used to make a finger prick smear as well.
Right.
So that thing actually when as a pathologist when we directly receive lymph node and nobody tells us what is there in the peripheral blood, tab is tarah ki problems sometimes they can arise. Eventually what we concluded that in the lymph node actually was a had a follicular lymphoma lesion with CLL. So it was a very rare kind of a thing because ये follicular lymphoma वाले cells clonal भी हमें peripheral blood में मिल गए थे along with CLL cells. So but this is very uncommon and very unusual. But it still brought us to the point कि अगर हमने डायरेक्ट रास्ते से चला होता और पहले पेरिफेरल ब्लड दिखा होता और लिम्फोसाइट्स देखे होते और फ्लो किया होता तो हम लिम्फ नोड के डायग्नोसिस में उतना स्ट्रगल नहीं करते. So मतलब ये है मतलब point is कि whenever we are dealing with a low grade lymphoma we should at least definitely have a good going look at the peripheral blood to rule out कि ये CLL तो नहीं है. And then if it has that low grade morphology, then our panel of markers which will include 5 and 10 will help us to differentiate between a SLL follicular and a mantle.
Do you routinely see the ultrasound findings for any retroperitoneal lymph nodes or anything?
No sir, मतलब overall if you ask me, I think
Or
SLL की
splenomegaly?
हाँ वो information हमारे पास आती है sir. When we get a
आती
lymph
है.
node, usually we talk to the clinician and I must admit कि हमारे पास सर एक रहमान है, वो जब तक पूरी हिस्ट्री नहीं मिल जाती तब तक वो छोड़ता नहीं है. So he ensures that all that information that is required, which is actually required when you are reporting lymph nodes की Hodgkin's है तो कहाँ से sample किया है, mediastinal mass था कि नहीं था, what group of lymph nodes are involved. Even the clinicians should understand that all this information has to be passed on to the pathologist before they start interpreting the morphology. So it is
Dinesh,
important, sir. I think
Dinesh wants to ask you how to differentiate typical CLL from atypical CLL.
typical CLL from atypical CLL, we'll call it an atypical CLL only when it is not typically fulfilling the immunophenotype of 5 positive, 200 positive, CD23 positive. So I don't know, atypical CLL हम लोग करते थे जो score we used to give a score of 5 markers which used to include CD5, CD23, dim CD79B, low expression of the surface immunoglobulins. So a score of more than 3 was used to be considered as typical of CLL, and a score of less than 3 but with a typical CLL like morphology is something maybe then I would say कि this could be an atypical CLL अगर उसमें 11 14 या और कोई जेनेटिक एब्नॉर्मैलिटी डॉक्यूमेंट होकर के वो किसी और स्पेसिफिक सब ग्रुप में नहीं जाता. सो अगर टिपिकल पेरिफेरल ब्लड में स्मच सेल्स हैं, छोटे मैच्योर सेल्स हैं, सो विच इज कि यार ये तो CLL ही लग रहा है, एंड इम्यूनोफिनोटिपिकली इफ इट इज स्टिल फुलफिलिंग मे बी 2 out of those 5 points or maybe 3 out of those 5 points, ideally you require more than 3 यानी कि 4 या 5 होना चाहिए आपका स्कोर. So a score of up to 2 or 3 में we might say that it is atypical CLL. The 20 expression would probably be a little brighter than expected. जैसा मैंने बोला कि normally CLL में 20 is dim as compared to 19. So sir, eventually what I feel is it will depend upon the clinician कि अगर तो patient को उन्होंने follow up में रखना है तब तो मुश्किल है. But if they anyways plan to treat him, so we all know that they will either give this kind of a patient also. We should talk to the clinician how do they plan to treat So if the 20 expression is there, they might give the patient on rituximab and so on. Plus, definitely we can go ahead for genetic profiling of that cell, and if we have mutations which are specific for CLL, which I just mentioned, then that might help us to establish a diagnosis of CLL despite the atypical CLL morphology. Maybe he can add on, because I really didn't specifically look up literature ki how do you diagnose atypical CLL. If he has something in mind, I request him to please come forward and answer also. Dinesh?
Yeah, waiting for him to come forward.
Yeah, waiting for like the
No, no, no.
kal
Thank you, ma'am. I think
Mhm.
you have already answered most of the thing, but there is some flow markers and some atypical presentation. There is now new classification for atypical CLL also. I not exactly remember, but they have given something and little more workup other than the uh, routine one.
So I think initially जो cases जिसमें, because वो scoring system अगर हम लें तो उसमें CD200 was not given importance, but now if you see that CD200 has really helped us to discriminate CLL from other markers. तो अगर हमारा typically 5 positive है या 200 positive है और 23 भले ही negative आ रहा है, अगर light chains भी बहुत bright नहीं आ रहे हैं, so I think overall we'll have to take a call whether you still want to call it a CLL and probably a atypical CLL. So then ये atypical CLL वालों का treatment would also be probably different from I think जो typical CLL का wait and watch वगैरह करते हैं ये लोग. So maybe we can read up a little more about
Yes,
atypical
ma'am.
CLL. Hmm. Anything else?
Yeah, no, I think your throat needs some hydration.
Sure,
You
sir.
must be. No, no, you must be really tired, non-stop, more than 1 hour, 20 minutes. Great.
Capacity है सर, बच्चे मुरे पे ही गए हैं.
That's
Yeah,
true.
yeah.
बहुत ही अच्छा बोला आपने, बहुत ही excellent, wonderful. The fluency is too good. I mean, the way it comes out, excellent. So
Thank you
then
so
I
much.
think we will call it a day. Thank you so much, Dr. Ruchi. Wonderful presentation. God bless you. Please share the PDF. We'll share with
Sure,
the
sir.
student. Right. Take care. Maybe sometime later in the month, or maybe after 2 3 months, we'll ask you to speak on something more.
Sure,
Maybe a
sir.
case presentation of typical and atypical cases which you see at your
Sure, sir.
center. That would be very interesting.
Yes, sir. My pleasure.
Right.
Thank you, sir.
Thank you. Take care. Bye bye. Good night. Take care. Bye.
Bye.
Bye. Thank you. Thank you, everybody. Thank you, Dr. Dinesh, Dr. Kusum, and the rest of the people on YouTube. Bye bye.
Thank you, sir.